Welcome to an update on healthcare in the era of a pandemic. Today's date is September 6, 2020. So some of the data you'll hear is going to be outdated by the time you see this video. But my principal message on what the pandemic has exposed is clear. We have the worst healthcare system among industrialized nations on this planet. I'm Alice Farina, survivor of private practice, academic medicine, Veterans Administration hospitals, neighborhood health centers, ending my career in Medicare Part B as its medical director for Ohio and West Virginia. I had enjoyed the practice of medicine until the 1980s, when doctors were assaulted by new organizations designed to reduce healthcare costs. Managed care organizations, health maintenance organizations, preferred provider networks, none of which I understood because I did not handle the billing. I focused on clinical care. Then I noticed that some of my patients would disappear without warning. A few years later, some came back, explaining that under their employer health plans, I had not been a preferred provider, and so they could not afford to come to see me, until I again became preferred. Now, how is that for continuity of care? Medicare taught me that government can get some things right. It introduced many efficiencies, like a uniform fee schedule, a uniform claim form, a computer program to detect fraud in billing, and a system of peer-reviewed research to determine what new technologies and treatments offered a proven benefit for coverage, with no costs for marketing, multi-million-dollar salaries, or golden parachutes. That is what led me to single payer action of Network of Ohio when I retired. I'm going to share some slides with you now. So just give me a moment. Single payer simply means that one fund administered by a nonprofit government agency would make all the payments for all medically necessary services, all, period. The 1,500 private health insurance companies that currently do this work, each raking in profits for its stockholders, and each with its own expensive bureaucracy and complicated policies, would no longer be involved as middlemen. Medicare is an example of a single payer plan. That is why SPAN and other single payer states adopted the terminology improved Medicare for all. While other industrial nations around the planet have been steadily moving into universal coverage since the 19th century, the United States has been stuck in a dysfunctional approach that makes us an outlier in terms of per capita costs, despite still having over 20 million people uninsured. The yellow bar at the bottom represents just the public costs in public programs in the United States. And you'll notice that with the exception of Switzerland, that is more per capita than any other industrialized nation. The orange part of the bar represents the additional healthcare costs that we pay through the private insurance system. The private corporations defending this costly healthcare system oppose Medicare for all, saying it would rob people of choices. So I ask you, which choice is more important to you? Choice of your insurance plan or free choice of physicians and hospitals to provide your care? Let's take a look at how we got here. Back in 1912, Teddy Roosevelt, noting the recent advances in Germany, ran on a universal healthcare platform but was defeated. 20 years later, his cousin Franklin was elected during the Depression. Although FDR did try to introduce the healthcare program, all he was able to get through a hostile Congress was the Social Security program. That lifted millions of seniors out of poverty. Health insurance companies came on the scene during World War II and afterward became an expected benefit of employment. Harry Truman tried again in 1947 to expand healthcare coverage, but failed. A breakthrough occurred in 1965 when Lyndon Johnson signed into law the Medicare and Medicaid bill, protecting even more seniors from poverty. 18 more years passed, and then Bill Clinton put Hillary in charge of developing a healthcare program, but that too failed, killed by Mitch McConnell. Is that a familiar name to you? Then, in 2003, the first single-payer bill, H.R. 676, was introduced into the House, where it languished for over 15 years, untouched. Finally, in 2008, the Obama administration was able to squeak the Affordable Care Act through Congress, but had to drop the public option, ensuring that universal coverage was not going to happen. The number of uninsured did decrease through expansion of Medicaid and making a variety of plans available for those who did not qualify for Medicaid. However, it actually added to the administrative costs of private insurance. People had to use exchanges, a new invention, in order to apply for a plan. There were several good features, however, including expanding free coverage of preventive services and protecting those with pre-existing conditions from losing insurance. Finally, improved versions of single-payer bills were introduced into the Senate. Bernie Sanders' Bill S-1804 in 2017, and Jayapal's House Resolution 1384 in 2019. Unfortunately, there is a deep partisan divide on this topic. Conservatives firmly support preserving a for-profit insurance system with no constraints on monopolies. And one of the biggest monopolies is the pharmaceutical industry. You'll see that more is spent on marketing and administration than either manufacturing or research and development. With no constraints on pricing, so their profits are among the highest in the Fortune 500 companies. Hospitals are also monopolies, mostly privatized now. They currently bill per item and service, greatly inflating the price of every aspirin or Band-Aid that you receive, because they can. Physicians spend the equivalent of 1 day per week on paperwork or telephone calls, dealing with denied claims and begging for pre-authorizations. So why don't we reduce this waste? We could negotiate for drug prices like other countries do, and even our own VA can do, but there are laws that prohibit negotiation of prices for Medicare and under private insurance. We could reduce the costs in hospitals by eliminating the super bills, creating a global budget based on expected costs for the year, and paying each hospital a monthly stipend. Ohio could save $8 to $9 billion by reducing inflated pricing. If we expand coverage to all those currently uninsured and eliminate co-pays and deductibles, there will be more spending, right? And more taxes, right? This is socialism, not communism, resulting in your loss of freedom to make choices and would bankrupt the country, right? Right? Well, first of all, provision of healthcare will remain in the private sector, which refutes the socialism charge. As to bankrupting the country, that is where our current pathway is headed. Let's look at the numbers. SPAN commissioned an economic analysis of a state plan for Ohio modeled on Medicare. It shows that savings can be seen in almost all sectors that I've mentioned. The blue portion of the pie is the savings in cutting the excessive administrative costs for providers. The large orange section are the combined savings by reducing monopoly pricing or getting rid of monopoly pricing. And the gray portion represents the administrative costs of private insurance companies. So how will we pay for this? Most of the money will come from existing funds folded into the new system. Funds that are already paid to Medicare, Medicaid, Children's Health Insurance Program, the military retirees, and Affordable Care Act subsidies. Then the savings that I mentioned in the previous slide would bring in $25 billion. That leaves $40 billion that would have to be raised through taxes. Oh no, you say, we can't do that. We have been conditioned by conservatives like Grover Norquist to say taxes are always very, very bad. Are they? There are some very bad trends going on under the current system, resulting in a steady rise in deductible and premium costs that come out of your pocket. The orange line represents the 162% increase in deductibles that we have seen. The next line, the green one, is the increase in family premiums. That black line near the bottom that you can barely see is the increase in wages since 2009. Employers are doing a good job of shifting costs to you in the form of out-of-pocket costs, so that by 2019, the average family premium was over $20,000, with the employee paying a little over $6,000 of that. The average single deductible was $1,655. However, there are many different plans, and those with lower premiums have higher deductibles, and those with high premiums have lower deductibles. My daughter actually consulted a family member who has a master's degree in health administration when she tried to make sense of the private plans available to her this year. How many of you have such resources? So what happens to household spending under a publicly administered plan? This shows the savings in the Ohio plan adjusted for income level. You'll see the income levels at the bottom range from $20,000 on the left to $150,000 on the right. The peach-colored bars represent what the current out-of-pocket costs are, and the green bars represent what they would be under a public plan. The bottom line is that you are going to pay for healthcare one way or another. Which pocket will have more money left in it at the end of the day? Well, clearly the single payer plan would. But all these numbers are from 2019 or earlier. Something happened in 2020, right? COVID. Suddenly, the US was hit with unemployment levels last seen in the Great Depression of the 1930s. This peaked in April at about 22% and is now gradually declining. But the future is unpredictable because this pandemic is still not under control. Between February and May of 2020, 5.4 million Americans lost health insurance. That includes 139,000 Ohioans. We see a secondary fallout from people losing jobs. They face evictions, food insecurity, leading to increased depression, suicide, other things that disrupt our social fabric. The hope of an effective vaccine being available this year are not founded on reliable data. The hospitalizations caused by COVID were massive and costly in both dollars and lives. We are told there may be another resurgence, sometimes called a twindemic, during the fall flu season. Right now, the projections are that the unemployment rate will continue to fall through 2021 if all we have to deal with is COVID, represented in the blue bars. But when influenza season starts, the combined effect could look like the black bars, keeping our unemployment in the double digits. This crisis shows us the flaws in the employer-based health insurance system. The director of research at the Economic Policy Institute recently said, delinking health insurance from jobs should be a top policy priority. He ended with a plug for Medicare for all. Imagine the relief of not having to choose between paying your health insurance premium or paying your rent, between buying medicine or buying food, and not having to worry about going bankrupt from a hospital stay, an emergency room visit, or a surprise medical bill from an out-of-network provider. and say goodbye to the maze of so-called choices. When your family needs health care, you simply go to a doctor or hospital anywhere in the United States, and it's covered without copays, without deductibles, without coinsurance. That's what Medicare for All is about. So join us, become an activist. Visit the websites on this slide and find ways to engage. Our strategy is two-pronged. At the state level, we keep introducing every biennium single-payer bills. I've already mentioned that there are two bills in Congress, one in the House and one in the Senate. We don't care which strategy is achieved first. Either will be a victory for the millions who cannot afford health care now. I leave you with the words of Winston Churchill to give you some hope. You can always count on Americans to do the right thing after they've tried everything else. Thank you for listening.